actually started my federal career after doing 17 years of clinical work on the Colville Reservation as the tribal psychologist in independent practice. Then I came to IHS as the alcohol and substance abuse lead in the Division of Behavioral Health in December of 2013, and recently moved to SAMHSA in February of 2014 to continue the work on the Tribal Law and Order Act. So again, I'm very honored to be here, and my co-presenter is wonderful Dr. Weahkee.
Thank you. Good morning, everybody. And you weren't too bad on my last name, so it was better than Weahkee's, which I usually hear. Thank you. Again, Rose Weahkee. I'm the Acting Phoenix Area Director, and previous to this position, my permanent position is actually Director for Field Operations for the Phoenix area, so I oversee a number of the federal service units there. As part of my background, I also had the opportunity to work. One of my first positions when I became a psychologist was becoming a program director at United American Indian Involvement. So I worked several years at the Urban Indian Program in Los Angeles, and so understand many of the issues and concerns and needs of urban Indian communities. I know that for many Indian people, we move from the reservation to urban areas. There's a lot of reasons why many of us have moved to urban areas, whether it's for health care, for other resources, for employment, for me, for education, and other times because there may not be the resources that are needed on the reservation. So working as a psychologist with the clients that came to UAII, for some of them it may have been a female who was escaping from sexual assault, and perhaps the perpetrator was still on the reservation and not had been convicted. Worked with young Indian females in our group home who also experienced that. Perhaps maybe had alcohol and substance abuse issues, and there were no resources, residential treatment facilities that were available. So I know that many of our urban programs serve not only the urban Indian population that are living long-term in urban Indian communities, but are also from reservations seeking services and resources that are not available in our own home communities. I also understand that, a lot of times people would say when we were trying to advocate and go to different meetings with the state and county, well, why don't you just go to this other healthcare facility? Why do you need your own special facility for American Indians and Alaska Natives? And so there's a lot of education that is still needed in that arena. Understanding again how important spiritual and cultural aspects are integral to the work that we do, and that's what we're able to offer to our community. We're able to provide that system of care. So a lot of our health centers are not just about providing health care, but a whole range of services, and being able to provide a system of care to the communities that we serve, as well as for me personally, and I know for a lot of the other individuals that worked at UAII and who sought services there, it was our family and it was our community, and that was very important to us, and also to the work that I do and that I continue to do, and I think that all of you do, and that's why we feel so passionate about and good about when we see those strengths and people aspiring to move on into their careers. So I did want to also mention, we've had a long-standing partnership with SAMHSA, whether it's been providing training, sometimes it's been responding to suicide clusters in Indian country. So we've worked together in partnership with not only SAMHSA, but our other federal partners, implementing different behavioral health provisions of the Indian Health Care Improvement Act, of the Tribal Law and Order Act. And so I really see this as an opportunity with Dr. Ronyak to be able to hear what your needs are and recommendations are with regards to this tribal behavioral health agenda. And really my role here is to help assist, get that information, and ensure that IHS leadership, SAMHSA leadership, and our other federal partners are aware of those concerns and recommendations, and see how we can begin to move forward and implement that and work in partnership with our urban Indian leadership as well. So thank you for inviting us, and looking forward to hearing the feedback that you provide today.
So as we're speaking of the background information of the Tribal Behavioral Health Agenda, how many people out there have actually heard the words Tribal Behavioral Health Agenda or the acronym TBHA as of this morning? Hey, that's what we thought. So this is exactly why we want to reach out to you. As Dr. Weahkee so eloquently put it, what we do in Indian country is not just in one community. It's not just in a tribal clinic. It's not just in urbans. It's not just in the tribal colleges. It's nationwide. It's a variety of settings. So what has happened on this tribal behavioral health agenda? Thank you. So if we think about why we're having this discussion, there's multiple reasons of why we're actually having this discussion. We know that there are continual needs within Indian country. We also know that there's a variety of ways services are provided within Indian country. And to give you just a little bit of a background of the tribal behavioral health agenda, we actually have, as you know, tribal leaders that have a very strong voice within their communities. You out here as our audience, as our urban communities, also have a very strong voice. What we want to do is hear all those voices. We had some tribal leaders actually speak up at one of the Secretary's Tribal Advisory Committee meetings, and they had said there are a variety of issues in Indian country that we need to address. So part of what we need to look at is the impact that behavioral health has on our Indian communities. We also need to look at how this correlates, as Dr. Weahkee was talking about. We have multiple sides to who we are as a whole person. Oftentimes we have silos that are working. We have, if we say the medical community, we have our substance abuse communities, and then we have our mental health facilities, and sometimes it's not really integrated. And so we had some discussions about what is the real definition of integration. And so that's something that we want to have more discussion about so we can kind of define that so we're all working together. So if we're thinking about what we need to look at, we know that more than just BIA or IHS needs to address behavioral health issues. We know that our behavioral health issues, as I said, are nationwide. So that means SAMHSA needs to step up. That means all our federal partners need to step up. And that is in reaction to our tribal leaders saying, we want a behavioral health agenda where all federal partners are working together to better behavioral health within Indian country. So that's exactly what this Tribal National Behavioral Health Agenda is all about. So if we start looking at the World Health Organization and how it defines wellness, I'm going to give you what their description is. It's a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. But if we think about it in Indian country, we know that many of our Native American communities will define it in a much richer way. It's including a balance between the physical, mental, emotional, and spiritual aspects of life that are embedded in our cultural identity. That's a different definition by theory. And that's what we want to have a discussion about today, is how do we take the definition of the whole person, the whole community, and put that into a national behavioral agenda that's guiding our work. So with that in mind, we need to talk about how this all came about. And really, we know that there was a presidential visit to Standing Rock. President Obama listened to the people. He listened to the children and our youth. And one of the things that he has done is the Generation Indigenous efforts. So with that initiative, we know that there's a lot of youth engagement happening. We know that there's a lot of attention on our Native communities, and we know that we need to take action. So this is the action that we're taking. We also know that within our communities, we have some tragedies. And one of the things that we know that hits the papers are all the statistics. So up here, again, we have the statistics. But what we want to do now is say, what are we doing about those statistics? What is working in Indian country? How are we addressing that? How are we including our cultural competency, even with our providers? So that's the direction we want to go. We don't want to sit here and look at all the statistics that tell us the things that are going wrong in our community. Honestly, I'm sure all of you know those things. It's not new information, but we want to talk about what's working. However, we do know that these issues are very important. We do know the suicide rate is extremely high. We do know that we have intergenerational trauma. We do know we have historical trauma. So now it's time for us to address that at the root of the problem. So when we're thinking about this, what we're wanting to do is hear our tribal leaders who said, we want to have a positive legacy. We do not want to have this same discussion 10 years from now. Those of you that have been in the healthcare field have probably heard this discussion for at least one whole generation. So now is the time that we want to take action and we want to make change. And so this is where your input of what you're serving and how you're serving your communities is so important, so we can integrate that into this important work. So this is really what we're envisioning. And I want to say that the reason we're envisioning this is for multiple reasons, but I want to kind of share that as we work through these slides. This needs to be a lean, and we ended up putting in there because this is our leaders saying, they said they want a mean document. So a lean, mean document. We're not talking a volume of papers where we know that it becomes a policy or an agenda, it goes up on the shelf, and we can check the box and say it's done. This is something that we can take action on. So this is a little bit different. So with this, we want to really have consultation with our tribal leaders. We want to confer with all of you. We want to have that input. We want to really reach out to all of our stakeholders. All the voices are so important to frame this national approach. So we want to build on many of the issues that are out there. We're calling them cross-cutting issues. So for example, we have youth issues that are cross-cutting. We have cultural issues that are cross-cutting. We have identity, and then we have individual self-sufficiency. Now, as this document started, it was really brought about by one tribal leader who was sitting at a meeting looking at one of the national newspapers. And they were looking at it, and they shook their paper, and they said, you see this? This article is about Sandy Hook. This article is about what our national response is to Sandy Hook. And then he said, if this happened in Indian country, would we have this response? And when that happened, that's what really generated the energy to say, we need to be proactive. We need to have a national response. Unfortunately, months later, the shooting happened with the Tulalip tribe. Did we have a national response like Sandy Hook? We did not. So what we want to do now is we are saying we got to keep this train moving. We want to realize that we need that national response just like Sandy Hook. And I'm going to talk a little bit more of that as we go through this. We need to raise the expectations of how we deliver care in Indian country, how we respond, how as federal partners we work together to make that immediate response, and how we can actually be more preventative and proactive. So part of this tribal behavioral health agenda is also having that piece of framework. So we want to talk about the scope of the problem and be inclusive. We want to break out of those silos. Like I was talking about, we have our medical fields and we have our substance abuse fields, we have our behavioral health fields, and sometimes we see them as different. But the truth is, a person is not different. We have all of those elements within us, so we want to address that. So as we think about it, the best way we can do this is to leverage all of the resources that we have, and that includes the resources that you're doing in your own communities right now. So with that, let's talk a little bit about the 4 cross-cutting issues. I had listed them out. So if you look at these cross-cutting issues, we're going to ask you for feedback. So we have them in 4 elements right now: youth, culture, identity, and individual self-sufficiency. Individual self-sufficiency came from one of the last presentations that was done at NIHB Summit. At the NIHB Summit conference, we shared this information. After that, I took this information to the Tribal Epicenter's directors meeting in Nashville at the first week of May. So each time we come into an audience and share this and take input, this is an evolving agenda. So your input is extremely important to add to this. So one of the pieces that got added, we moved from youth, culture, and identity, and now we've added the piece of individual self-sufficiency. And what they're referring to is somebody becoming self-sufficient on themselves, not having to depend on, let's say, TANF with a tribe, or not having to depend on the tribe for services, but starting to stand on their own feet and provide for their family and continue to be that positive role model in the community. So again, if you're providing us input, we may add another element. And so I want to make sure we save enough time to have that discussion, because this is about an agenda that can impact the whole nation. Here are the 5 fundamental elements. And again, we started with 3, and now we're at 5. Because again, this is an evolving vehicle, if you will. So each of the input dates, each of the conference dates, each of our listening sessions will help continue to build this. So with that, right now we're looking at historical and intergenerational trauma has been identified. We're also looking at national awareness and visibility. That is exactly what we're talking about, the Sandy Hook and the Tulalip responsibilities. We need to be able to raise the issues that are happening in Native communities, in our American Indian communities, Alaska Native villages, and raise that up and say, what is happening is so important. It needs to be addressed nationally. We need to look at the social-ecological approach. This got added into it because as we started talking to different venues, different conferences, different audiences, we recognize there's a need to look at the whole person. As a clinician, I've always worked holistically with my families. Well, why wouldn't we look at making an impact unless we're looking at holistic approaches? The other piece that came in is prevention and recovery support. And with that, there's a whole change in how we talk about intervention, treatment, and recovery. If you noticed, recovery has now turned to long-term recovery. We're starting to frame things of long-term recovery is the expectation that someone may relapse and they need to get back into the game and continue their recovery process. So language has changed in some of the literature that we've seen. Language has changed in the approach. Language has changed also in some of our RFAs for our grants that we're talking about long-term recovery. Not just someone goes to treatment, they come back, and what are the services, what I call post-vention or post-treatment. We're talking long-term, all their life. We're working from a disease model that every day they're taking on this challenge and we're continuing with them every day. So that's how we want to wrap this agenda around is how do we help the community every single day? And the last element is behavioral health services and systems improvement. We separated this out from prevention and recovery support for 2 reasons, and you'll see that as we go further. So we want to look at what are our priorities and what are our action steps that need to be in this lean, mean document. We're hoping it not be more than 30, 40 pages. We're also hoping that this is something that all of our federal partners and our communities can really say, we're going to take this and we're going to move with it, and so we can also have some influences down the road. So let's talk a little bit about some of the questions. So, number 1, when we broke out historical intergenerational trauma, what we wanted to know is how should historical and intergenerational trauma be framed? So on here, you'll notice on the bottom, those are our recommendations. So the question to you is the same. How should historical and intergenerational trauma be framed? These answers up here are the ones that we've received from the various audiences that we've talked to. And what we tried to do is group them if they will. So this kind of brings me back to my whole qualitative research days. So I was sitting here thinking of coding. So as you see, we have based on communities engaged separately. We also have defining historical trauma as the root of the cause. We know that our tribal leaders, that was the first thing they said, is that historical trauma is the root of the cause. And we have all these symptoms, the domestic violence, alcohol abuse, etc. So if we really focus on the root of the cause, we should see, by theory, the rest of the elements in a way come in place into more of a healthy healing. Then we have focus on healing, and what does that really mean? The other issue that came up is educate individuals, different impacts for the 566 tribes. Again, this is about the uniqueness and respecting tribal sovereignty. This is not a cookie cutter model. So that's why it's so important that we hear what you have to say and how your urbans may be addressing some of these issues differently than within small villages or within some of our tribes. The other piece of it, well, I actually just talked about it, I apologize, is that this isn't a one-size-fits-all. So if there's things that you can help us define what does that mean, that would be extremely helpful. Yes, sir.
It seems to me that maybe communities of color should stop trying to own historical and intergenerational trauma so uniquely. When they do talk about Sandy Hook, people focus on video games and the kid,
Do we have other thoughts about the question? Other things maybe you want to think about your community that you serve? How is historical trauma identified? And thank you, sir, for your input on that piece, because I think there's a lot of things we can think about. If we just think about 9/11, is that now considered a historical trauma event? Has that impacted people? Yes, ma'am. Thank you, Chance.
Okay, so I work in Baltimore. We're on the East Coast, and I work in our urban Native community. And actually, on my way here, I got a call from one of the parents who had to pick up her Comanche daughter from school because she had been called a redskin and was upset. And in our area, as you know, there's huge defense for the ability to appropriate. And that's kind of how we also look at historical trauma in our urban community, that our ability to identify ourselves as Native people, because we don't look like what other people think we should look like. That has more authority over our identities than our representations ourselves. So when people say, well, we have bigger things to worry about than mascots or appropriation, as an historical trauma researcher, I see all of these things as related. So I would like to see a bigger stance on that. I know the White House Initiative on American and Alaska Native Education is focusing on this and how mascots and appropriation impact educational attainment, but we see that it impacts the identity and resiliency of our youth, and that's a problem.
Thank you very much. I appreciate that. That's a very important element that's come up, and I'm glad that it's actually raising some national awareness, and we will add that to the notes. Thank you. Any other thoughts on historical trauma, intergenerational trauma, how it's impacting your community, how you've seen it with some of the patients or clients that you're seeing, or including some of the family members? Because as we know clinically, often when the patient or client is coming in, what their so-called issue is not really the issue we end up working on. So the treatment plan obviously from day one completely changes by the time they really feel comfortable to talk about why they're there. So if you can think about that in your head of what are some of the reasons people are coming in? Is it related to historical trauma? Is that something we need to take into account as we're trying to define historical trauma?
The definition of historical trauma, I think, needs to be conveyed or shared with local people. I mean, as professionals, we talk about it, but when you really try to ask a question to auntie or grandpa or whomever, they're not going to understand what we mean by historical and intergenerational trauma. The other issue that I wanted to bring up is grief. When families experience grief, there's no support for people in those situations, and people carry it forever. I think that has a large contribution to this whole issue. And so developing more support mechanisms for everybody in the families, and everybody experiences grief on a daily basis, but many do not understand it, many never talk about it, and many just carry it forever. And so I think that has a lot of impact on an individual and community's lives. Thank you.
Thank you, ma'am. I appreciate that. Kind of to piggyback on that, I think you're absolutely right. My grandmother was in a boarding school, and she will not talk about it. And to the day she passed away, she didn't share with me. And where I worked clinically was at the same boarding school. And actually, when I got a job there, her reaction was, "Oh, honey, no, you can't work there." So I think you have a lot to be said about how does that impact the next generation, not only the person that it's happened to. And unresolved grief, for those of you in urban communities, we know that sometimes the families aren't as tight as on the reservations because you're all right there. On my home reservation right now, we've had 11 deaths in the last 3 months, and I have a family member attending a funeral on behalf of our family since I'm not home, and it's the third burial in 7 days for one family. when one person was trying to go to the funeral, they got in a motorcycle accident and they lost an uncle that day, on the same day they were burying somebody. So I can completely understand the unresolved grief. And maybe let's even think about, how does that incorporate our traditional beliefs? You know, each tribe responds to grief, and we honor the person who has passed to let that spirit join the other side in different ways. You know, maybe taking down pictures, or smudging the whole house, or giving away all the personal belongings, the burnings, things of that nature that you can't speak about that person for a year. And think of this family that's just lost 3 people in less than 2 weeks. How does that impact it? So that's a very good point. Thank you. Yes, sir.
10 years ago, the Red Lake community suffered an historical 6 kids shot in the high school. And it obviously affected everyone. I think the IHS response was good. The problem, though, was that 10 years to even today, the community is still having issues with that, with the trauma related to that. So last month, the Senate committee came up, and we were talking with the tribal council, and we came to the realization that we had 6 federal agencies dealing with the same problem, that we weren't talking to each other. BIE, IHS, SAMHSA, the DEA, and some other DOJ, and some other agencies, and including the tribe. So the issue for us was, how do we, even 10 years from that date, how do we coordinate and how do we heal the community? It was, and we're still having those issues. It's turned into an opioid problem because of injuries and self-inflicted wounds, continuing with the suicides, those kinds of issues. So I think the point would being that it's yes, healing families, but healing communities in a way. And we, you know, IHS may not have all the resources, but there's 6 federal agencies that do. So the issue for us is, how do we coordinate care? How do we provide a cohesive and competent level of care? How do we help? How does the tribe take leadership for those issues? How does the families take leadership to do that? And I think it's an incredibly dramatic issue that we have to face.
Thank you. And so if I can summarize, not only is it about coordination of the feds, it's about how does the tribe lead their beliefs and what they want, so the feds can then implement the resources. Is that what I'm hearing you say? Okay, thank you.
And you know, real quick, I'm sorry, I know I'm just kind of like the MC or rover, but yeah, the event that he talked about was March 21st, 2005, where the young man went and shot his grandfather and his grandfather's girlfriend, and they went to the school. I just came back from Red Lake, and I tell you, he's right on the money when he says, like, a lot of these organizations aren't really talking to each other and working together. I had a really cool conversation with this young lady and my brother here from New York City, and one of the things that we're talking about is how we can bridge the gap from the professional perspective and from the youth perspective. Going to Red Lake on the 1st of May, and then going right to Tulalip on May 7th. What I'm getting from both of from the community is a story. Then what I'm getting from the students is, we don't want people to come in here and tell us how we're feeling, what we should do, how should we respond, what we're going through. We want people to come in here and love us. We want people to come here and tell us jokes. We want people, so, you know, and the only reason, I'm sorry about that, I'm sorry to kind of interrupt things, but, you know, one of the things that they talked about was, you know, one of the very first things that they said was youth, you know. You know, my mentor back here, he was the one that said, you know, if you want to change in the country, get involved with young people first. And that's something that I see that SAMHSA is doing. I'm very grateful for that. November 17th, we all gathered out in Crystal City in Washington, D.C., and SAMHSA brought over 300 young people to come and talk about these issues, to come and talk about those matters. So I kind of wanted to plug SAMHSA for the great job that they did in bringing that, but also, you know, it is important for us as professionals to be able to collaborate with the #1 influence in the world today, which is ages 13 to 24 years old. They are our real leaders, and we have to find that gap there, and I think that's what we're doing. But like, you know, this gentleman said here, all of our agencies have to come together and work and collaborate. I'm sorry, I just really love Red Lake, and I really love Tulalip, and I had the privilege of visiting both of them within the same week. So,
Thank you. Those words are very important because I noticed Dr. Weahkee is taking this in. Again, all voices. Those who are out in the field, it's important because we do know federally, we're like 30,000 feet up here. And unless you've come out clinically, you know, I'm asked all the time, what did you see? What did you see? You were in a boarding school for 7 years. What are the issues? We got to make that connection. We've got to make what the communities need and what we can do federally up here and coordinate those services. So thank you, sir. And please know that that is one of our priorities in the office that I'm the director of. And if we have time, I'll talk a little bit about tribal action planning, which is that whole coordination of federal responses and utilizing the tribes to be their voice to make that change and develop strategic plans to address issues that are not just come in, there's a deployment, we're in there, we're out, and then the community's trying to figure out what to do. This is about coming in, helping them, and continuing. So thank you, and thank you. And Chance, did you have another? Oh, thank you, sir.
In our area, we have 13 main tribes, and one is federally recognized. And so we work through a lot of issues pretty often. I appreciate the efforts for that focus on one definition of an urban Indian, or you know, the efforts with Congress. We had a little reminder when we started doing healthcare reform, because California wasn't as sensitive as they should be when they, you know, when it came to whether you were a member of a tribe or, you know, California tribe. So anyways, that was a big issue. One thing I did want to say, when we focus on the youth, a lot of these people are cousins, you know, they're second cousins, even with the federally recognized tribe, and the youth are friends and they don't get it. So it's kind of refreshing that the youth is kind of the bond or the strength in the community that puts the families together, because some of the other generations, they still want to fight and say it's not fair. You have you have your own healthcare facility, you have your own tribal hall, you have a casino, you have all of those things, and they'll be second cousins, and you know, they're living and now finding out that, you know, they may not qualify for everything that they thought they might. So that, you know, I like your focus on the different impacts for the tribes, and one size does not fit all. It's not just the federally recognized tribes, it's the other tribes as well.
I just wanted to make a comment. I'm Crow. I was raised Crow, and I'm fluent. Crow language was my first language, and I learned English later. And we still, you know, have a lot of our protocols and our culture intact. And I'm also Catholic. And we also observe a lot of our, you know, our spiritual practices. And as a child, I grew up in both worlds and just made the transition real easy without thinking about it. And now I'm realizing that there's a way of thinking that's native, that's Crow. I guess I can speak for Crow, and there's a way of thinking, a way of thought. And then I transition over to the white world and understand that way of thought too. I went to this, just to make it clear, I guess I went to this tribal planning session in Montana, and I was really excited to hear what the tribes were going to be doing. And arrived, and, you know, no offense to white people, but there was a white woman, the whole first half day, maybe the full day, she talked about grant requirements and all these hoops we had to jump through to meet the needs of all these grants, and to make sure we made it sustainable. They like to throw that word in there, to make it sustainable. Boy, I was pissed. The whole morning I was sitting there just fuming. And then I watched, and the natives went to do their plans, and they made it so it fit her needs and not the needs of the people and the way the people think and what they do. And then, you know, they throw out that sustainability, and it doesn't work that way. You take that money away and that grant is over. Guess what? As soon as it's over, we're back to being Crow. We're back to being Blackfeet. We're back to being Sioux. That's what's sustainable. And so my recommendation is that the entities listen to the tribes and what they're already doing. What are there's a couple of buzzwords, protective factors and the strengths of the community that are cultural. Identify those and support those. That's what's sustainable. That's what we go back to doing after 5 o'clock, after work is over, or after the grant is over. And they don't seem to understand. They want to throw out all their grant requirements first without listening to the people and where they're at, where the tribes are at, and those strengths that are sustainable, truly sustainable, that we live every day. And so I just wanted to share that, and that you would consider that in when they provide funding, and make it so that they don't change their ways for that 2 years of the grant, but the grant supports a lifetime of well-being.
Very important.
Thank you for giving me a chance to make a comment here. My name is Ken White. I work with the Native Americans for Community Action in Flagstaff. And this is really important here because we became involved in the historical trauma effort through a effort by a gentleman. His name is Dan Press. And Dan is a civil rights attorney in Washington, D.C., and he's retired, and he became a Columbia University professor. And I don't know if you know, but Mr. Press was one of the individuals that created the tribal employment rights offices throughout the United States. So Dan is a well-known individual, and what he has done is he's created a movement along with Senator Heinkamp from North Dakota, and they've had 2 roundtables. They had a roundtable last August, and they just had a roundtable here on March 3rd. They invited all the federal agencies to come to the roundtable and the tribes, so the movement is starting to go. So I just want to share his email address. Just email him and ask him, can you please give me some information on the historical trauma initiative that Senator Heinkamp and him are spearheading. And his email is really simple. It's D as in Dan, S as in Sam, P at VNF. That's DSP at VNF. What that means is Daniel S. Press at Van Ness Fellman. They're the civil rights, Native American civil rights law firm in Washington, D.C. There's tribes all over the United States trying to pursue this historical trauma. We're going to have a meeting next Friday, the 29th. We invited 200 people from Arizona and the tribes and IHS, so it's very important. And just one final comment, the behavioral health and mental health services that are being developed from the Western model, those are just Band-Aids. The real core of the problem is the historical trauma our Native people have suffered over the years. So I would really encourage you to join this movement that's already in motion. Contact DSP at VNF, and you'll get some really, really good information. Thank you.
Thank you so much for sharing about the crows, because you're right. This is not just, we can't just answer one question. It flows into all of the questions. And that's the beauty about this National Tribal Behavioral Health Agenda. It needs to be fluid. We can't say we're trying to look holistically at people if we're saying we're in silos in questions. So please. Okay, so number 2, we talk about national awareness and visibility. Here we have 3 different questions. You can answer any of the 3. So first off, we have, how might behavioral health issues and their underlying causes be more effectively communicated with tribal communities and across broader national audiences? And the gentleman speaking about Red Lake gave us some ideas on that again. And so again, this is a very fluid type conversation, so feel free to kind of take some from one piece to another. The second question is, how can all levels of governments and other stakeholders provide national visibility? And when we say governments plural, we're meaning the federal and the tribal. That's why it's plural. This is a government-to-government relationship. We have to recognize that. We're not just talking about the feds. We're talking about that tribal input. The third one is how might communication and collaborative actions be incorporated into existing efforts? So we got to put our thinking caps back on. Many of you might just be busting at the seams to share something with me, and I'm looking at you, Sarah, because it may go into this. So please raise your hand, and Chance will be coming around again. Thank you, sir. Do you have the mic over there? Oh, here comes one. Oh. Thank you.
Good morning. My name is Maurice Smith. I go by Mo. I'm the new executive director for the National Council of Urban Indian Health for NCUIH. And I just been aboard probably less than 3 weeks. And first of all, I want to acknowledge the good work that not just SAMHSA, but other agencies that are doing in Indian country to respond to some of these crises and these issues. I'm somewhat familiar with SAMHSA. I came from Kaufman and Associates as a TA specialist. And although I wasn't focusing on a project that pertained to suicide prevention, intervention, treatment, so forth, I was aware of some of the work that is going on there. And my supervisor, Iris Prettypaint, Dr. Iris Prettypaint, asked me to sit in on this tribal committee teleconference. And this is prior to coming to work for NCUIH, so I'm wearing a different hat. But I want to give some feedback on what I observed. And maybe you can note this and take it back. First of all, it was very informative. The platform, the audio was horrible, okay? And when I look at the word effectively communicate within tribal communities, and I understand the effort, and that's why I applaud SAMHSA for being actively and engaging and looking to how we can improve the process. The audio was poor. The second part was, it was a tribal advisory committee. And my experience, just being Native and Indian man, and whether I'm in an urban community or a reservation, a lot of our people, our ways is we'll sit back and listen. And the facilitation process of this call, whoever was facilitating worked for SAMHSA, and she guided it the way she wanted it. She did not, she overstepped her boundaries as a facilitator. She did not facilitate a participatory process. Okay, that's the second point. And she's very bright, I don't know, and I'm sure she's a decision maker there, but she guided it, she did not facilitate, and facilitation is an art. It's an experience, and if SAMHSA, what she might want to think about is getting someone that's independent, that can facilitate that tribal call, that allows a tribal leader to engage, and it's an art, okay? The other point was, it was a 4 to 5 hour call.
4 to 5?
Yes. It was a 4-hour call. Wow. And I'm not sure what committee it was, but it's a standing meeting, it's a standing call, and it's a tribal committee on suicide prevention. And so there was 3 observations I made, and so when I look at tribal communities, and who do you report to at SAMHSA?
I report to Mirtha Beadle. She's the director of the Office of Tribal Affairs and Policy.
Okay, wasn't
So we're
her. Wasn't her. But
It might have been the TTAC, the
Okay.
Tribal Technical Advisory Committee, and that's an all-day meeting that most
There we go.
leaders fly in for. That's in person. Unless they can't fly in, then they may be on the call, and that is an all-day call.
Yeah.
Okay, thank you. That's good input for
So-
me to take back.
Please, the work, the intent, effective communication is understanding the communication styles and process of Indian people. And there was 3 things that happened, and I came in, and I was assigned to sit in on that and take notes. And so I just wanted to share that. for whatever it's worth. So, thank you.
Thank you very much. It's very important because not only are we talking about the efforts we make to arrive at events like this, we're talking exactly about that, sir, is how do we improve our communication? And not only will SAMHSA work on that, all agencies are working that. I know IHS is working on that tremendously as well. And in fact, some of the agencies, and I can only speak of SAMHSA right now as far as what I know, have developed a communication strategy with our tribal leaders and our tribal communities just for that issue. And so I will take that back to add that in as well. Thank you very much. And next, anyone else have a mic? Any other thoughts as far as national awareness? And I want you to think again about some of these answers may kind of overlap. You know, we did hear from Red Lake. Thank you very much. And so if not, we'll move to the next question. And again, if you have thoughts, please feel free to write them down and we can circle back as well. So if we move to our next one. Oh, I apologize. Here, it was too much to put on one slide. Here are some of the ideas that came up. So for example, just to look at some of the recommendations that we had. We had starting with the family and community, which we've heard right here, and I'll come right to you, which we heard right here in this room as well. We also had changing the school curriculum. How many of you have seen that they're talking about changing, and some states are saying we are adopting that, we are changing our history? I mean, I applauded that. I was so excited. I was like, it's about time. It's about time. So then we have our positive negative focus on media images. So this is a lot of the PSA work that we're doing, not just print, not just radio, but actual handouts that are within the community. Having possibly TV spots if we needed to. We know in Indian country, we also have some tribes that have their own radio stations that are still doing like Indian bingo on nights and have a language program that's a part of that. Where are our PSAs? You know, how do we loop that in so we have positive messaging going on over and over? And again, we have involving our youth. Our youth is our key. And it was said here in this room, and I thank Chance for bringing that up again, that our youth is our key. I think many of you in here will agree with that piece. And then we have the voices of our survivors. We can learn from them. That's what was said. We need to learn from our survivors so we can make the future better for our next generations. And identifying budget and resources is kind of coming back to our grant opportunities that we'll talk about. And Chance, we have a gentleman in the back. Just one second.
So I actually just missed it. I had to go out and get caffeine like you. Well, you have energy. I can't even stay awake right now. But so I just wanted to add on to the national awareness and visibility. It'd be great if we would get a plug from SAMHSA about our population, where we are. We do have the data. So Byron Larson is here. He's the director of the Urban Indian Health Institute. So he's over in the other room. He has a phone call that he has to be on. But we have that data. It's not easy to get. It's outside of our PMS. We have to data mine through all different types of places, usually through emergent care, things like that. There's all kinds of issues that we have to deal with that with data quality, but it is out there, and what we're not seeing from SAMHSA is also getting that holistic picture of where our entire population is. So it is good to talk about what we're talking about as far as the symptoms and what's happening out there and how we can address that, but also from SAMHSA getting it out there that our population lives elsewhere. 71% of us live outside of these reservation areas that honestly a lot of this is really directed towards. So we need to start talking about the population where it is holistically throughout the entire United States and not just in this one area. So we are Indians, we're not just tribal folk. Okay, so that's something that we like to get out there and start to get that data to inform other people where we are. And there's also a difference in how our service deliveries are reaching our people. So using the UIHO model or the UIHP model is a good way to start.
Thank you. And actually, just to speak to that, not only are we talking about the National Tribal Behavioral Health, SAMHSA has developed with its partners to deal with the Tribal Law and Order Act, the scope of the problem. We now have a new data evaluation work group that's with federal partners. And so not only is it IHS, DOJ, SAMHSA, our other federal partners, but we've reached out to ACF, they're at the table, NIH is at the table, NIAAA is at the table. We are gathering all of that data exactly for that reason. We've reached out to our techs and trying to figure out how we can incorporate that data so we can have the most broadest view of where our communities are, and exactly what you said, that they're not all in tribal communities. There's a variety of venues that we have tribal people. So let's move to the next one because I just looked and went, oh goodness, we have like 10 minutes left and I want to make sure we get through all of these. So on our social ecological approach, we have 2 questions. Are there other partnerships at all levels of government with tribes to address social, policy, and economic factors that have shown improvement? And are there American Indian, Alaska Native specific models that address social, policy, and economic factors that should be showcased in the TBHA? So here were some of the answers. So let's start with this and see how we may expand this piece. So one, we have the sovereignty approach. Again, it's that we are not a cookie cutter. One size will not fit all. And I think everyone in this room can see that because I can look around the room and look at the different communities that are represented, and there is no way we can say that the West Coast is the same as the East is the same as the South, let alone the uniqueness within each of those communities. We also have the importance of the matrilineal society. It was brought up that we have spiritual connectedness, which was brought up again in this room. We have teaching to build houses to reduce dependency. So this kind of speaks to that self-sufficiency. It's talking about not only utilizing the resources, but utilizing the skills within the community to build their own houses, to build their own resources. We also talked about the impact of activity or extracurricular activities, and that's not always just in the schools. That's some of our cultural activities. And it was interesting because they said, well, it's not really an extracurricular, it's our traditional ways. But it was a way that it was just put on the slide. The other piece is needing to grow your own foods and addressing food efforts in our community. Many of us also know that we have lands that can build those foods and help them be self-sufficient where they're sharing healthy foods among the reservations. So these were some of the ideas that were brought up. Do we have other thoughts in the room as you're thinking of how it may impact some of our urban communities? All right, I'm going to move to the next one just so we can try to get through. If you have an idea, don't feel like you can't raise your hand because we can keep on coming back. Prevention and recovery support. So this one and the next one I really think are going to probably overlap, and we may hear a lot on this. So our questions that we had is what should be included to address discrimination and negative attitudes about behavioral health? What factors should be considered in facilitating engagement of individuals, families, and communities in culturally appropriate prevention and recovery support? This is ongoing support. And what strength-based approaches would best capture culturally appropriate prevention and recovery support? So now you notice, and we had that discussion in here, we have our Western ways of evidence-based practices, and we now know we also have our promising practices. So a lot of the answers here were focused on moving from our evidence-based practices, EBPs, moving over to promising practices, looking at how is that impacting our grants RFAs. I think many of you will be shaking your heads going, yes, and it's speaking exactly to what you had spoken to, is the fact that we're now being asked to take a circle and fit into a square peg. Why can't we take a circle and fit into a circle? So as you see in some of the recommendations, that was one of the first things that was brought up, and evidence-based practice is discussed almost in every meeting that I'm in as far as how do we make that shift. So with that, when we're looking at the different grant opportunities, we also have to talk about where is the research. And this is part of why SAMHSA and our federal partners said we've got to build a data work group. We got to get the data from every resource we can to identify our scope of our problem and identify the best practices that are out there so we can now leverage and have some sort of data that will support that our promising practices, what's working in Indian country, is helping with the healing. So that is definitely one of the goals. So again, as you'll see some of the things up here that were brought up, early intervention. Many of you know that a lot of grants and even Title XIX reimbursement, Medicaid reimbursement, does not reimburse for prevention. We know that issue. Those discussions are happening at CMS. Actually, as soon as I'm done here, I have a call with CMS to continue those discussions. So those are continuing to happen. We know that we need community planning. That was mentioned. We've got to focus on how do we continue with the funding. Yes, we use the buzzword sustainability. Sustainability may not always mean financial sustainability. It may mean health. It may mean wellness. Yes, ma'am. Got a question in the back there, Chance.
Was it really a question?
Oh, or input, thank you.
Well, just about the prevention piece, that's one of the areas that we focus on in our facility. And what we found is mentorship is one of our most important evidence-based practices. And what happened is that we have a summer program, we have a leadership camp, and we have wellness nights once a week. And what we found is in our own staff, we have about 50 staff members. And of those staff members, about a quarter of them have gone through all of those programs, starting out in our summer program, then through our leadership camps, and then off to college, and have come back. And one of them is now our clinic director. So we have a lot of it. I think that really works for us. But the problem is we don't get money for prevention. So we have to find all kinds of ways to get the money to run those programs.
Thank you. Thank you for that input. And I know Dr. Weahkee is writing frantically over here, so thank you so much. Appreciate that. Okay, hang on one sec.
Check.
And mind you, we have 3 minutes because I am watching the clock, but all your input is very important. Thank you very much. Yes, ma'am.
I really just wanted to reiterate what was said in a previous comment about, I understand all the input so far has been from a tribal perspective, and one of the challenges that we face at the urban programs is really about that need to fill the community. Many of us are looked to be a community-based or community center type of philosophy, and right now there's nothing that allows us to do that. So really, if you really want to help the urban programs, that would be one area to look at, because it does lead to prevention, it leads to that leadership, it leads to that sustainability and holistic approach to healing, because right now we just don't have the capacity in many of our facilities because we're held to those strict guidelines. You have to do X, Y, and Z, and you can't go outside of that, and you can't see this person. When I look at mental and our counseling and mental health programs, that's many things. We're turning people away because they somehow don't fit a box, and that doesn't work for me. We've now established programs that we can still get them in, and we pay for it in a different way through our organization, but again, we're not able to provide that, and with 70% of the population in our urban communities, we really need resources specific to us. So there is tribal resources, we know that, and we appreciate all the work that you've been doing there. I come from the Weahkee tribe, I'm a Weahkee tribal member. I think you guys have done a good job with many of the programs that they receive, but it doesn't necessarily help me reach and provide support for the community I serve. Thank you.
Thank you. Appreciate that. And let's do one more, and then we'll move to the last question. Yes, ma'am.
Hi. I'm glad to hear that there's a data work group, and I was just wondering if that work group would also be considering the evaluation process that is often accompanied with some of these programs that are funded. At least for our community, I feel like recently we are funded by a SAMHSA Systems of Care grant, and our proposal incorporated a lot of community-based and cultural interventions, and that was funded. And so I've seen that flexibility at least starting to happen on the program side. But the national evaluation process, I don't think, has caught up to that, and so it's still evaluating the effectiveness of these services, even though they're funded, in a way that completely doesn't match what we're actually doing. So it's not going to demonstrate any effectiveness, because it's just like you said, it's trying to fit a square peg in a round hole. It doesn't work. So I hope that that work group can also consider the flexibility with communities putting together their own evaluation processes that are really going to show that it's working. And I know that's not always easy to do, but I think we've found that the technical assistance resources have been really, really helpful, and we actually have created our own very strong evaluation data collection process, but there's still that requirement to participate in the national process, which is very different from what we're actually doing.
Thank you for that. Just to provide an answer for you real briefly so we can move on. I drew the lucky card. I'm on those groups too. So not only are we looking at that on the RFA piece of it, I've actually just joined a work group to look at how do we have more culturally competent evaluation piece that I'm working with one group. The data work group, they're working on another piece, which they're still bringing in that evaluation, because from the research, that's one of the issues that we're recognizing right away. And then at SAMHSA, they do have what we call the SAINT group, the SAMHSA American Indian Alaska Native team, that we've brought some issues as far as research and evaluation that SAMHSA as a whole are looking at. So I can answer that from SAMHSA's point. I don't know if Dr. Weahkee, if you know anything on IHS, if you're changing any structure at all. An evaluation piece?
I mean, most of our grants, like the MSPI and DVPI, support the local evaluation and trying to develop the capacity at local communities. So we're definitely in support of that effort.
Yeah, thank you. So I hope that answers your question. And I have some business cards, so I'll be sure to share my card with you so we can talk more about that. So let's move quickly to the last one so I can try to keep you on schedule, because Chance will be here telling me real quickly that we got to move on. Okay, so our last one is, how might the federal, tribal, state, and or local programs be better aligned to address behavioral health and other healthcare personnel shortages, kind of coming back to the service piece, in American Indian and Alaska Native communities? And when we're talking about communities, we're including urban. So this isn't just about tribal communities on a reservation or Alaska villages. The other two questions: what efforts are needed to support a clinically skilled and culturally competent behavioral health workforce for American Indian and Alaska Native communities? And then what points on a care continuum include traditional Native medicine should be integrated to improve the health and well-being of American Indian and Alaska Natives? So as you see, this is where we're talking about fluid. Chance, there's a question in the back. This is where we're talking about fluidness of this report. We can't just put them all in one question, because we're going to have discussion that's going to flow. So here were the recommendations that were made. So with this, we have value our traditional evidence-based practices, cultural competency for non-Native providers, do the grow your own models and keep your own incentive packages, which kind of speaks to your leadership package. Lack of government-to-government recognition at all levels, which is affecting funding. That was brought up today. Better networks and coordination. That was brought up today. And parity across services. This is very important. That was brought up. That funding and training and recognition of the importance of wellness and healing is not necessarily the same in behavioral health, in our medicine arena, in our law enforcement, in our courts, in our juvenile systems, things of that nature. So that was brought up in this last bullet. So I'll open it up to any input. And we have one back here. Thank you.
So I guess it's a little bit more of a comment, but it is also a question. I wanted to know about the conferring policy, because I don't know that urbans have a conferring policy with SAMHSA. It seems like in a lot of ways that we're left out, and I say this because over the past couple of years, we've talked to our area coordinator for SAMHSA several times, and he ends up apologizing to us every time because urbans are always left out of the funding. And it's very important that we get that. Again, 71% of us live in off-reservation, you know, because we're not getting access to that. So part of the recommendation I really would like to add is, like, do we have a conferring aspect? Because it doesn't seem like we're having access to let you know what our BH services and systems are in the first place, because they're very different from what's happening in the tribe. Our reimbursement systems are very different. Ours have to do with the state for the most part, you know? So it'd be good if we had that access, because in the past we're left out of these things, even with the American Indian Alaska Native group that SAMHSA created recently. That was all tribal. There was no urbans in that. So it's good that I know you guys had that agreement with Byron recently, and so that's a step in the right direction. But we'd like to see that a little bit more in conferring, a little more administratively with the urbans directly.
Yes, and actually we are in the process of setting up a meeting in August. So they are finalizing some of those things right now, which will be known as the NOTR, the National Tribal Organization Representatives, I believe is how it stands. And so that's part of the process that SAMHSA is doing, because we've heard what you have said. We've heard that we need to kind of stretch out to that. So they're working forward on that piece. However, one of the important elements that we all know is that as agencies, lobbying is not one of the things that we do. However, you as communication pieces, speaking to tribal leaders, speaking to the community members, knowing that you service tribal members from another community in an urban setting, having your voice heard with those leaders so those leaders can then take that forward and go and request on their behalf as the tribes, that piece is very important. They need to be able to also be sharing not only what does their tribal community need there on the reservation, but what does their members who are living in urbans need as well, and have that shared with Congress. So that's a very important piece as well. So do I have any other recommendations off of this last slide? Thank you.
Thank you. I'm Donna Keeler. I'm the Executive Director at South Dakota Urban Indian Health, and I'm currently serving as the NCUIH President. And I do appreciate you coming, and on very short notice. I just feel it's, in all fairness to all the programs and also to you as presenters, that the request of this presentation actually resulted from a FACA issue. And that's with Jackie Mercer basically being told that she could no longer sit at the table in a national behavioral health work group. And that she could not only not sit at the table, and she's chaired this for several years, but that she literally had no voice. And the only voice that she had is if she could get a tribally elected official that she could speak through, which is just what you just said. And if she could do that, and if she could find a tribally elected official that would do that, that official could not speak on behalf of urbans. It would have had to have been a tribal-related issue. And so I was at the tribal governance meeting in Reno in April. And this presentation, I happened to go to this outbreak session, and this was the presentation. And my question after that was, you know, have the urbans even been considered or involved or asked? And that's why this presentation actually, you know, got put on the docket, because it does seem like we are completely left out, and that this has been a very much an afterthought of including urbans, even in the conversation. So I kind of wrote down, are we considered stakeholders? I mean, is that where we fit into this? Or,
yes.
So
yes.
as stakeholders, how do we get a voice in this?
And that's where we're trying to go around the FACA issues and figure that piece out that we've been working on, because it is very important that we hear from you. And I think it's been said here numerous times that we know 71% of our tribal membership as a whole are in these communities, in urbans, right. And it's extremely important. But we do have to follow the guidelines. And when the FACA issue came up, it's how do we still reach out? And so we are working diligently on that. And that's exactly why, as partners, we've had those discussions looking at how can we hear this voice. And we thank you for allowing us to come on the agenda, because it is important. This conversation, this discussion, the notes that we have to add into this piece helps us get that voice without being on a federal work group, if you will.
Right.
So we're still working on that. And as we get more information, we will be happy to share that with you so we can have an avenue to have that voice consistent, right. And discuss, you know, what would confirm it look like on a regular basis.
And I think the voice from not only IHS, but I think SAMHSA and every other agency is that this originated in 1976 in the Indian Healthcare Improvement Act. We were just born then. So we had no idea what the dynamics would be nationally. Mm-hmm. So I think that when it's that, well, we can have these urban groups and then come back to that information gets back. By not being at the table, at the discussion point, you lose a lot. You lose a lot of the connectivity between us and tribes and what that conversation could evolve into. And then also the tribal partnership with us. It just seems to, you know, continue to divide and separate us. And so we need to find a way that we are not an afterthought, and that people that are very knowledgeable in this field are allowed to sit at the table and give input.
We hear you, and we are working on that. So We will continue to work on that because you bring up some very important issues that the voice is very important. And if we can figure out a way to make that work, we are happy to do that. So we are still working on it. Thank you. Any others? We have and I'm going to bring the last slide up just so you can see some of the input pieces that we're needing for you to just kind of think about real briefly as well.
Can we
Yes,
go
sir.
back to that other slide? I'm sorry.
How many slides? That one?
Yeah, and this comment may not pertain to that particular slide. So when I look at value traditional evidence-based practices, I know, I'm not a scientist, and I know every generation there's a new term or new strategy, evidence-based approach. What is evidence-based, just in one term?
The way it has been described at SAMHSA, here's the difficult piece of it. I will try to make it as very quick and a summary. Is with evidence-based, when something is reported as evidence-based, it's really the research of the treatment. How well is the research of the treatment done? Not how effective is the treatment. So there's a problem. So we're looking at how much research has been done on a particular treatment and how well has that research been done. But it may not incorporate the effectiveness value of that piece. And so if we say, like with CBT, cognitive behavioral therapy, there's oodles, literally, of research out there. There's thousands, hundreds of thousands of articles on CBT, whether it's anorexic populations, whether it's trauma, you name it. So all that research that's done, if it's done well, then it's considered evidence-based. But it doesn't mean it's talking about the effectiveness. Are they researching the effectiveness piece? So one of the elements we're having discussions at SAMHSA about is we know Native communities were protective of research within our community. So there is not a lot of research on our traditional practices, if you will, that are being done in our community. So how do we move that leverage?
Okay, thank you. It leads to my next comment. And for me, I don't have a doctorate, okay? There's a couple terms that you're using that I like. Wellness approaches, cross-cutting. And when I look at that bullet, value traditional evidence-based practices, I want to share quickly a story. These urban Indian communities have their own wellness stories and examples. And I'm from Denver. I grew up in Denver, and I'm also from Tuba City. So I'm urban and I'm rural. I don't know. I'm just an Indian man, okay? But 20 years ago, there was 3 guys in Denver. Robert Upham, my brother, Darius Smith, and Clark Tallbull. And they created the Blue Pony Lacrosse. It's not an evidence-based approach, but they created this project which was a demonstration of wellness. And what they did was they took a concept called lacrosse in Denver, and they said, this is the creator's game. And they start teaching the urban Indian community about the significance of lacrosse, that it's an Iroquois sport, it's a spiritual sport, and they start teaching about how we have to claim this back, and it's not a prep sport, but it's our sport. It's called the creator's game. And what happened was these kids start walking around carrying their stick, and they built it, they created their own sticks, and they didn't teach them the game until they had a full understanding of the significance of the game and the origin of the games. So here you had these little kids walking to a park, and they started to play it. They understood the significance behind it. But what happened was every Saturday, people start coming to Sloan's Lake Park in Denver. And it started out with 2 or 3 people. And then they started having practices. And they created this community where kids and families would come out, Indian people would start cooking and grilling, and no bacon grease though. That's an Oklahoma thing. That's Oklahoma City. But I share this story with you because it's an active program now. it's a wellness. It's a really demonstration of wellness of an urban Indian community that took our game and reclaimed it and said, this is our game. It's not a preparatory sport. Yes, they do play it at those schools, but they learned it from a fundamental. Now, here's a demonstration of community wellness, okay? So when I think of value of traditional practices, it's not evidence-based. Right. But when you have 40 families that show up on a Saturday to support their kids, isn't that a demonstration, an evidence-based practice? So somewhere in all of this, we have to go to look at the urban Indian centers and communities we represent. And I've been to most of these communities, and I can speak to it. And I just shared one example where we thank you for coming here, but let's take off the scientific hat, because Indian people have been studied to death. We've been studied to death. And I'm standing here as an advocate, as the newly hired executive director. Don't fire me yet, because I'm just getting started. But let's look at some value traditional practices that are not evidence-based, that have the potential, okay? And each one of these communities, I guarantee you, they have a Blue Pony lacrosse story.
I'm going to turn and take it back. Yeah, it's good. Go ahead and turn it off and take it back.
Thank you very much. You know, and as you say that, the only thing I can really resonate with very quickly when we think of what the federal partners are doing, I have to reach out to my IHS partners here. At one point before I moved to the job I'm in, I was a project officer for MSPI and DVPI. There is a demonstration project that there are beautiful stories just like that of what those funds, how IHS distributed those funds, those demonstration projects have addressed what we would put in this bullet as an evidence-based practice that worked in their communities, that they have used those MSPI and DVPI funds to address the uniqueness and have prevention, have intervention. Some of them have even developed post-vention plans to suicide, utilizing federal funds, utilizing their cultural uniqueness, and IHS shares that on their website as the promising practices, and that's exactly what we're talking, is taking that needle and how do we move it over so that we can incorporate all of these wonderful healing stories. So thank you very much, I appreciate that. And Chance?
Yeah, did you
Last
have
one? Okay. So let me go to our last slide, and I greatly apologize that we're over. I know I messed you up. Okay, so here's our last piece. This is where your thoughts, where we can make this change, and I said that this TBHA, it's evolving. Are there other thoughts that you have that are cross-cutting issues that we need to address that we didn't address in the beginning four? So if remember, our beginning four elements, let me check my notes here because I want to make sure I tell you the exact right thing. We have youth, which we've talked about. We have culture. We have identity, and I love the stories that were shared here in this room about identity. There's a lot of issues around identity for a variety of reasons. And then our fourth one that was added from our last discussions and interactions was the individual self-sufficiency. So is there any other cross-cutting issues that you think we need to add? Or do you agree with those four that we have identified thus far with the various audiences we've talked to? Crickets. Just kidding. I want you to really think about that. Does it meet what you have, your needs in the urban settings? Yes, Mo?
I think you're on track. Yesterday, we had a discussion with the directors about thinking outside of the box, so to speak, in the realm of how can we collectively unify and really elevate that awareness and visibility and have that cross-cutting approach to advocacy, education, outreach. I think in addition to the national, as long as you don't lose sight of that there's a regional and a local approach. So there's local, regional, and national, because again, we have unique audience, and what works in Baltimore may not work in Missoula. So that would be the only thing I would add, is that it's a national, regional, and local strategy of awareness and visibility.
Thank you very much. And then on our foundation elements that we have, mind you, remember we talked about historical and intergenerational trauma. We talked about national awareness and visibility, social-ecological approach, the prevention and recovery support, and then our behavioral health service and systems improvement. Those were our 5 elements. Are there other elements that you can think of that need to be a part of this national behavioral health agenda that are occurring within your unique communities that is something we've got to put on the radar and we've got to address? Yes, sir.
I don't want to take much time, but devastating effects should probably be shared with the Department of Interior, OIG, since
Okay.
the Bureau is to blame probably for them.
Okay, thank you. Very important issue. Thank you for sharing that. Any other thoughts? Okay. Are there other considerations that SAMHSA and IHS should address that we didn't discuss today, that doesn't fit in any of the slides, doesn't fit in any of the categories, if you will, that we were bringing forth? And so this is free reign. And I hear loud and clear that we need to have an avenue so the urban voice is heard. So that may be something that we have to take back, that it's not just a part of this agenda, but it's a part of the way we work. So thank you. Anything else? Okay.
Here, one more, Angela, right here.
Oh, okay, thank you.
What about incarcerated individuals? In our urban area in Dallas, we're real close to Oklahoma, which they have a large population of American Indians and Alaska Natives. And what we see, because in a small community, they stand out more because family know family, and you have the rumor mill. So they think they'll have a better life if they come to the city. But then they find out that they have bigger issues because city life is a lot different than living in the country.
Mm-hmm.
So what is your recommendations on providing counseling on the behavioral issues that follow these people that have been incarcerated?
Okay, so what I'm hearing you say is we really actually address incarceration and reentry. Okay, thank you very much. Because we're working on that in some of our Tribal Law and Order Act, but this is definitely a very important point that we can add to this. Thank you, appreciate it.
We got Mr. Larson back over here.
I knew I couldn't leave without Byron saying something. Please, Byron.
Dr. Ronyak, so nice to have you here as well, addressing the urban programs. And as you heard earlier, that there's some issues in terms of the way that the consultation process goes. There's FACA requirements, of course, and but there are some other avenues for us to do that with SAMHSA. As you're aware, SAMHSA has 2 committees that are internal at this point, as far as I understand, and that you know, it would be nice to have representation in terms of urban programs on either of those committees potentially. And also one other related item in terms of like ACEs and historical trauma and kind of what SAMHSA is doing in that regard. Maybe comment about that a little bit. If you've already done that, then that's fine, because I missed a couple minutes. Those would be my main points.